All this means that this book, and a fresh look at the lessons it contains, is more important today than ever before. With one final important difference, the lens now must be population-based. To eradicate inequity in American healthcare, it is no longer sufficient to look at discrimination only in healthcare. We must look at how racism, bias, and discrimination infect all of the social determinants of health, both historically and contemporarily. Providers must understand that their patients who belong to racial and ethnic minorities are affected by discriminatory housing practices, mortgage lending, maintenance of substandard conditions, properties, evictions, accommodations. All aspects of housing for minority residents and homeowners have been infiltrated by ugly, health-harming racial and ethnic biases. Inequitable discipline in schools, disproportionately high arrest rates, sentencing, and exposure to violence scar children and adults for life. We are only now beginning to fully appreciate how stress, anxiety, and serious mental illness associated with discrimination and racial violence adversely impacts the health of vulnerable communities. Those wishing to implement the healthcare delivery model outlined in this book must make room for these structural concerns. Training a generation of de-biased providers is an essential and necessary component of reducing health disparities. However, those de-biased individuals must appreciate their roles as caregivers within a social context where racial and ethnic biases adversely impact every facet of their patients' lives and health, particularly their patients who are members of Black, Latinx, and Native American communities, if these providers hope to deliver quality health care and give these patients a fair opportunity to live healthy lives. In short, to cure racial inequality in American healthcare, doctors, nurses, administrators, social workers, psychologists, dentists, physician's assistants, and all of us who are patients must now account for and take aim at the impacts of racial and ethnic inequality in healthcare and in each of the social determinants of health. This book offers a way to approach this task by providing a framework for critical self-evaluation and reform within the healthcare delivery system and a prescription for changes beyond healthcare. Now, more than ever before, we need the tools offered in Just Medicine. Introduction. The New Normal. For the past 30 years, medical doctors, social scientists, psychologists, policy analysts, jurists, and a wide spectrum of healthcare providers have been studying and discussing health inequality in America. Meanwhile, by one estimate, 83,570 minority patients die annually due to healthcare disparities. Black and brown patients consistently receive inferior medical treatment, fewer angiographies, bypass surgeries, organ transplants, cancer tests and resections, less access to pain treatment, rehabilitative services, asthma remedies, and nearly every other form of medical care than their white counterparts. Yet, minority patients are sicker and more likely to die than whites from a wide range of diseases and illnesses for which we have data. Certainly, this picture is complicated. For example, health and illness for all racial and ethnic groups follow a social gradient so that minority populations which disproportionately occupy low socioeconomic strata also predictably suffer relatively worse health outcomes than whites do. Although it is popular to blame the poor for their poor health by pointing to risky health behaviors, careful studies of nationally represented populations conclude that the significantly higher prevalence of cigarette smoking, alcohol consumption, obesity, and physical inactivity are only one aspect of the relationship between lower socioeconomic status and poor health. Moreover, behavioral disparities must not be taken out of their societal context, where unequal exposure to the stress of discrimination, inequitable